if I may start. Thank you. I would like to welcome you all here to the first International Esophageal Atresia Patient Journey Symposium here in Berlin. For those of you who don't know me, my name is Anne Dimarakis. I am the newly elected president of KEKS and mother of a child with esophageal atresia. Today we will have many interesting presentations about the surgical and multidisciplinary challenges associated with esophageal atresia and the challenges the patients themselves face on their journey with this disease. And I have this little clicker here, so I can change the slides myself, because we now prepared just a small presentation, really small, it's just one slide, about KEKS. I can change it myself. For those of you who don't know KEKS, we are the German patient organization with about 1,600 members. We are ourselves a member of the international organization EAT, of Rare Disease Germany and EURORDIS. Our medical hotline, for example, manages about 600 calls per year. And natürlich, ja klar. We are not just nationally connected, we are internationally connected with IONOEA. We are active in ERNICA and in ERNLUNG. Two of the most important projects we are currently doing is, for once, the developing of the KEKS clinic certificate, EA Best Cert, and the follow-up examination manual. So as I promised, it's just one slide about KEKS, so you know a little bit about our organization. But enough from KEKS. I'm very glad to be here, and I'm looking forward to all the presentations. I'm now handing over to Anke Wiedemann, fellow member of the board of KEKS and president of EAT.
Thank you very much, Anna. Thank you very much. I'm waiting for my slide. First, a warm welcome from my side as well. I'm really happy that we managed to organize this while we have our 40th KEKS anniversary. And EAT is the federation of all support groups globally. I'm very happy to welcome Joanne Fruthoff from Fox, my vice president, and all the speakers who took the travel, and it seems to be, as it was a challenge, to arrive in Berlin today. We have a few people online. Please let us know via chat if you have a question, if you don't get the message, if you don't have a good tone or picture. We have a competent team of technicians here in the Karl-Storz-Haus who will try to fix the problem. I can go to the next slide. Yes, this is EAT. We have 15 groups globally. We will show later a slide how everything started, and we are member in EURORDIS, that's the umbrella for the rare diseases in Europe, and in Rare Disease International, because although we are often not looked at as a rare disease, the treatment of our children do have the same problems like other rare diseases. That's our medical community. We are working in our national groups with the national medical societies. We are working on European level with the scientific societies. We have IONOEA, the International Network on Esophageal Atresia, or PAFIS, but IONOEA is our major network. And we do have national and international medical boards in our patient support groups. And we do have the European reference networks. Originally only ERNICA, where we are as esophageal atresia, but we start to be more connected with the ear and lung for the lung issues of our patients. So what are we doing? EAT has a philosophy of collaboration. We are collaboration amongst each other, with parents, with families, with other support groups. But as well, we try to connect, to coach and contribute to research, to clinicians worldwide. So this is what we are doing. I need the next one for the introduction of my very good friend and our founding president of EAT, Graham Slater. He's one of the oldest survivor, I may say. He's more than 7 decades ago. He had his surgery. He's still running the 5 kilometers, as he told me. He has 2 daughters and 3 grandchildren. And everything began somehow with his visit on the cake's 25th anniversary. So that's why this is an important day that he is with us. And he is on top the Black Pearl awardee 2022 of Eurodis and now board member of Eurodis. And he will be your moderator today, together with Professor Lacher. But Graham will introduce his colleague in the moderation. So I hope you have all a very nice afternoon. I hope you enjoy our session. Besides surgery, although we will have a lot about surgery, we hope that you can see that surgery is important, but in a way only the first step on a long journey for our patients. Thank you very much. Graham, please.
So, good afternoon, everybody. Guten Tag. I've been introduced. I don't think I need to introduce myself anymore. I just want to say a few words at the beginning of this session today. It's a great privilege to be here, and it's a great privilege to be moderating this event with Martin Lacher. And you might also notice when he stands up that quite coincidentally we are a very good example of patient-clinician partnership, because we have the uniform. We have the light brown shoes and the blue jacket, so all very, very coordinated. What I just wanted to talk about very briefly is the way in which the whole process of clinician-patient partnership has kind of moved forward. On this diagram here, you can see that on the left-hand side, we had very much a clinician-driven approach to the research and the development of care pathways. And more recently, that has become something which has been partnered with the patient organization. And we've also moved, I like to think, towards a process of lifelong consideration of the implications of esophageal atresia. We know, unfortunately, that we have patients who require care well into adulthood and sometimes for what we expect to be their entire life. So, what is it that we bring as patients? Well, we obviously bring a different perspective to all of this work. We bring the perspective of our experiences, either as patients or as parents, and that is complementary, of course, to the experience, the expertise, the competence that our clinical colleagues bring to surgery and to other medical disciplines. And this is a symbiotic, I believe, relationship, and it's helping us to deliver what is common to both the patients, the parents, and the clinicians and the researchers, which is that we are striving for improved long-term outcomes for our patients. And one of the ways in which we do that, as I say, is by a good structured approach to collaboration with mutual respect, with a good framework for working together. This has been helped, I have to say, in more recent years with the European reference networks, which have given us an infrastructure to work within, but it's not the only network that we operate in. And some years ago, I talked about what I called the 3 C's. And that's collaboration, collaboration, collaboration. And the collaboration number 1 is collaboration amongst clinicians and amongst patients. It's also very important to say that that's multidisciplinary collaboration. It's surgeons, it's physicians, it's speech and language therapists, it's a whole gamut of medical professionals. There's the second collaboration, which is the collaboration that is required across various networks. We have our international network on esophageal atresia. We have various networks within the European reference network community. And the third collaboration is the collaboration that we need to bring in each of our individual countries to ensure that we implement and gain benefit from all this good work that is going on internationally, at European level, at national level, and so on. So this is what I just wanted to set the scene with, and it's really now my great pleasure to introduce you to Martin Lacher from Leipzig, the head of, I think I'm right in saying, the head of pediatric surgery, and over to my fellow moderator. Thank you.
Yeah, thank you, Graham, for the kind introduction, and welcome everybody to this afternoon session. It's a great honor for me also to speak here and moderate this first session with Graham together. Graham mentioned the 3 C's: collaboration, 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 multidisciplinary in international networks, and also the translation to the national networks. He introduced another C, which is coordination. We were by incidents like with the same dress, and I want to introduce another 3C, which is centralization, centralization, and centralization. In this first session, we have a lot of talks about this topic. First, neonatology with Professor Bührer, talking about the obstacles we face in Germany. Then the case load-driven approach by Dr. Wilms, and then the multidisciplinary approach by Professor Böttcher from Mannheim, who will join us very soon. But we don't have to reinvent the wheel. We can look at other countries like Sweden. You know, there's no way not to deal with Sweden, right? Everybody loves Sweden, right? There's Björn Borg, right? There is ABBA, right? There's innovative things like Spotify, right? Come from Sweden. And there's also IKEA. We say IKEA, right? And you know, esophageal atresia and IKEA it has a lot in common, right? You know, you have one good chance to set it up, right? You set it up and everybody matches, right? But if you are undoing it and move to another house and try a redo, it's really difficult because it all falls apart, you know? In these terms, there's IKEA and there's, of course, Jan Svensson and Michaela here in the room. Okay, so let's jump into the middle of the things we discuss maybe after the first 2 topics, because they, I think, both deal with centralization, and then we have another discussion after the second 2 topics. So I will introduce the first speaker of this session, which does not need a lot of introduction. He's distinguished neonatologist from Berlin, head of department of Charité neonatology. He dedicated part of his career in improving the outcomes of the neonates with congenital malformations, and also with the instrument of centralization and regionalization. His expertise and leadership had made him one of the prominent figures in the field. And Professor Bührer, we are very honored that you share your insights on the regionalization and the obstacles we face in Germany.
Thanks for the nice introduction. As of course, I have to start with my conflicts of interest. I guess there are none. I'm employed by a state-run university hospital and have a fixed salary. It's always the same. There are no incentives linked to the economic performance of the hospital. This is a quite recent investigation showing health expenditures in various countries, and life expectancy at birth. And as you see, in many countries like France or Japan or Spain, life expectancy has risen sharply, while health expenditures have only risen modestly. There are just 2 countries where life expectancy hasn't risen over the last years. One is the United States, extremely costly system, and the life expectancy hasn't risen for 10 years in a row. And the other one is Germany. Life expectancy hasn't risen for 3 years in a row. So we have a very expensive, very non-efficient health system. And the currency when it comes to babies is not life expectancy, but infant mortality rates. Now, if you look at 1970, Germany was in between our role model Sweden and Italy. Now, among these 3 countries, we are the worst one. We have the highest infant mortality among these countries. And if you look at OECD countries, we are just about in the middle between Norway and Turkey. So we have a poor system, which is very costly. Now, and it's not because we are not spending money. As far as spending money is concerned, we are among the most expensive systems. Just the United States and Canada is more expensive. And we have a lot of hospitals. Again, OECD. Germany has one of the highest rates, numbers of hospital beds per inhabitants. It's about 3 times the number of hospital beds you would have in Sweden. So if you look at infant mortality, you have to think what drives infant mortality. And infant mortality is driven by 2 areas. One is problems related to pregnancy, placenta, parturition, prematurity. These are all P diagnoses in the ICD-10 system. That's about 50% of all infant deaths are related to this part. And about a quarter of all deaths are related to congenital malformations. So 75% of all infant deaths are related just to 2 areas. If you look at it from an individual perspective, the mortality within 1 year in healthy babies above 2,500 gram birth weight without a congenital malformation is about 0.1%. And it's 100 times higher both in infants below 1,500 gram birth weight and in infants with major congenital malformations. So these 2 areas deserve special attention. Our health system is not cost efficient, it's not sustainable, because all these hospital beds, they need a lot of money and they need a lot of personnel, which is just not available. And it's strongly influenced by healthcare providers, by the association that represents hospitals, by associations that represent doctors, but it's not influenced by organizations that represent patients. Now, my special area is neonatology. I'm not a surgeon. And if you look at mortality rates of babies below 1,500 birth weights, and you look at the annual number treated in these hospitals, small hospitals have a mortality rate which is about 50% higher than large hospitals. So by transferring all babies to the large hospitals, you would save a lot of babies. You would save about 20% of all fatalities. I told you, our role model is Sweden. And Sweden has a surface area which is much bigger than that of Germany. But there are only 8 level 3 neonatal intensive care units, 2 of them in the same city, in Stockholm, as opposed to more than 140 in Germany. So this is just wrong, and it's not cost efficient. So one way to tackle that is to have minimum annual numbers of patients required for reimbursement. So that's probably the best way to go, because these numbers you cannot talk around them. They are just, you have them or you don't have them. And it started about 10 years or 18 years ago. They were introduced for certain areas like pancreas surgery or liver transplantation. And now in the last years, it included also preterm babies below 1,250 grams. Now the new number is 25, which is not big. If you would increase the number further, let's say to 60, we could save 60 lives annually. But it was not possible to do that because of the stiff resistance by various politicians. We are just at 25, and we would need 60. But there's stiff resistance by local politicians. A politician which says, let's close our hospital, or let's make it smaller, can be ensured that he is not re-elected. And there's stiff resistance by physicians in chief, because they lose personal income and they lose prestige. And the fear is if you regionalized, if you make special care only available in certain hospitals, then general care also will not be available anymore. So there's general fear that hospitals are being closed. But it's not about closing hospitals. It's about putting hospitals into perspective. And in rural areas, there's fears of being left out, that all the specialties go to the big cities and people in the rural areas are left out. And then all across Europe, you have these right-wing parties, and they love that. And there is the risk, or an argument is that there are increased distances to reach a hospital. I just show you that this is not a real problem. First, if you look at special babies, those below 1,250 gram birth weights, they comprise about 6 or 7% of all newborn babies admitted to hospital. So the hospitals can still survive. They don't need these few babies. It's just a matter of prestige. That every small hospital can say, we provide care at the level of a university hospital. And the other argument is, if you close hospitals, you need more time to reach a hospital. And even that is not really true. It's true for some areas. For example, in Baden-Württemberg, it's one area north of the Lake of Constance. But in general, the most areas which have too many hospitals are the metropolitan areas, like the big cities. And you could easily close hospitals there. Does not take anything away from the population. Thanks for listening.